have all of you. Please follow us on social media and subscribe to our YouTube channel. This webinar is being recorded, so you can take a look later. And if you find this webinar interesting, please share the link of the YouTube to your colleagues and your team. I just want to remind you that we have an appointment with Dr. Anderson and an amazing panel to talk about morphology. He is restarting his series this year with a different approach. It's going to be very interesting. And this month, we still have the fetal webinar in the last Thursday of the month. And in the beginning of March, we are going to have another webinar of the of the Journal Club after Dr. Gary Webb. It's going to be very nice, and we hope all of you can join us. And I just want to remind I don't know why my screen is not working, but anyway, we are going to have a special edition of the Children's Journal about pediatric cardiac surgery. Sasha and Luciana da Silva are the guest editors, so please send your research, and they're waiting for your manuscript. I'm sure this is going to be a very nice edition. And now Gail is going to talk to us a little bit about what he's had prepared for us for today and about the World Congress. Thank you very much, everybody. And please, this panel is amazing. Type all of your questions on the Q&A chat box, and everybody's going to be very happy to answer your questions by the end. Thank you very much.
Good morning, good afternoon, good evening, all around the world. Thank you for joining us today. I have to tell you selfishly, I got to invite some of the people that I respect so much and have worked with and have read about, and I'm really looking forward to the panel discussion today. Sasha or Grace, before I forget, Dr. Limperopoulos, I think, has the wrong link. If somebody could send her the panelist link, that would be terrific. Dr. Dudekem, the surgeon that I work with, has the fanciest camera. He's able to zoom in on himself, and that's very nice, Eve. I love that. So Grace has told you about some of the events. For those of you who don't know, the Congenital Heart Academy started as a response to the pandemic in March and April of 2020. And I've learned so much through it. I've learned how much of a global reach these kind of meetings can have, how our colleagues are just so generous of their time. It's just a really wonderful thing to see. When we get to the panel, we'll have introductions at that point. But let me sort of see if I can get the share screen stuff to work here. I think it's this one. Yeah. So, what are you seeing now? I have too many windows open. Is it my slides or it is in presentation mode?
It's your slides.
It's your slides.
In presentation mode?
No, presentation. Yeah.
Oh, great.
Mm-hmm.
I've passed the first test. So this is something I've always wanted to do, as the arc of what I've been doing in my professional career has involved both intensive care and long-term follow-up, particularly of cardiac issues and neurodevelopmental issues. And it's been clear as we've gone along down this path that neurologic problems are prevalent, which we'll talk about, that the risk factors for them are cumulative and multiple and, interactive. And finally, what happens in the CICU is just starting to be investigated in terms of what are modifiable risk factors. And that's what I plan on talking about at the beginning of this. I'm joined by my colleague, Melissa Jones. Melissa is a nurse practitioner in our cardiac intensive care unit. I've had the pleasure of working with her for over 5 years now, and watched the growth of her passion, which is improving the care of kids in cardiac ICU and many others. So you'll hear from her on how our program was built. Let me see if I could advance the slides. So Melissa and I are where that pin is in Washington, D.C. Our panel comes from all these different places. And we did that not only for an international approach, but also we have psychologists, surgeons, intensivists, just a lot of different people who look at this particular challenge through multiple different lenses. And this is sort of a microcosm of what we plan to do for the World Congress. The World Congress, I'll tell you a little bit about the history. So there were separate meetings of pediatric cardiology and cardiac surgery up until 1989. And then it was obvious that cardiac surgery and cardiology would do better off having their own combined meeting because of the synergy between the two disciplines. That was held in Paris in 1993. It was scheduled for Kobe, Japan, but because of the nuclear tragedy, it needed to be moved to Hawaii in 1997. It was decided then that it would be every 4 years, like the Olympics. The next one was in Toronto. The one after that was in Buenos Aires. Wonderful meeting in Buenos Aires, followed by Cannes, Cape Town in 2013. And then originally scheduled for Istanbul, and at that time, it was moved on very short notice to Barcelona for the last one. Now, set against that background, my friend and colleague, Dr. Jeff Jacobs, who at that time was a surgeon at All Children's in St. Pete, and I was at Children's in Philadelphia, had put on a number of postgraduate courses, and we've worked together doing medical education. And we thought to ourselves, maybe it's a good idea if we put in a bid to bring this to the United States. The idea formed at the Super Bowl here in the United States in 2009, which was, of course, between Pittsburgh and the Cardinals from Arizona. We put together a coalition, about 30 children's hospitals in the US helped us get some seed money. We put an entire team together, and then against 7 other countries, the USA was awarded the bid in 2015. We had looked at both San Francisco, Chicago, and Washington, and for a variety of reasons, Washington turned out to be the place to have the World Congress, and this was decided 8 years actually before I moved to Washington. I never would have expected that I would be here where it was. We were awarded the bid for 2021, but because of COVID, we are now having this in August of this year in 2023. So we've been planning this for 14 years. It's 6 months away, and I think it's going to be terrific. And we took a page out of the book of what happened in 1993, and not only did we have cardiology and cardiac surgery, but we've added our key alliances with anesthesia, nursing, intensive care, neonatology, adult congenital heart disease, everyone who touches congenital heart disease and acquired heart disease in children and young adults, fetal development, neurodevelopment, et cetera, et cetera. I'd like you to sort of take a look at a quick movie.
I just sent it to Catherine.
No, I'm not. I have.
You're going to change it.
Yeah. See how many participants are on the bottom of your map. Can you see?
317.
It's usually about a third. So as you can see, there's something for everyone with this. And I hope you'll strongly consider joining us. And it'll be in Washington, D.C. from the 27th of August till the 1st of September, which is Labor Day weekend here in the United States. We anticipate somewhere between 4,000 and 5,000 people. As you can see here, 15 societies have agreed to not have their annual meeting in 2023 and instead devote all of their efforts, their attendees, and their industry support to the World Congress. So it's like 15 meetings in one. And here's our QR code. And we hope that you will sign up for updates. The abstract session is open. The abstract submission is open. The registration fees are online, and hotel and registration will be open in about 2 to 3 weeks. The program at a glance is online. Now, if you're using your phone to check that QR code, or if you're not, please either take it out or look at this QR code, because we're going to, in a little bit, do an audience poll that I think will be interesting. And now I'm just going to jump into what I'd like to talk about, which is the brain and how we affect it and how we can do things better in the cardiac intensive care unit. I do want to thank our collaboration with 4 societies in particular: the Cardiac Neurodevelopmental Outcome Collaborative, the Cardiac ICU Society, the Fetal Heart Society, and the Neonatal Heart Society. This is an example of, and also the World Society of Pediatric and Congenital Heart Surgery. I should put that on there as well. And this is an example of the collaboration that it takes to improve these types of things. I'm going to talk a little bit about history, the scope of the problem, the mechanism of brain injury in children, and Melissa will talk a little bit about next steps. So before I start, I'm going to try to switch this screen, new share here. And if you could log on to AHA slides. Let me see if I have that. There we go. So if people are on, you should see this picture. It looks like we have about 30 people on. So I'm going to give you a little bit of time. This is a practice question to see how your system works. Take your phone out to do it. And we're going to be doing some fun stuff at the end of the session. I think we have 300 and something people on the webinar. So far, we only have, well, 2 people are laughing, so that's good. 47 people are logged on. While we do these practice sessions, I think you'll get an idea of what we're trying to accomplish here. So just to be clear, for people who don't know, this is a bird over here on the left. This is not a bird. This is Larry Bird, basketball player. The dolphin is not a bird. This is Charlie Parker, who is Bird, not a bird, but just Bird. And this is Jeff Bird. If you don't know Jeff Bird, he is a cardiac intensivist in Philadelphia. So that should have helped you. You should be seeing the answers that you submit. Remember, at the bottom of your phone, if you use it, you need to hit the submit button. We have one more practice question while many of you are still logging in. If you had one superpower, what would it be? So you should be able to see the second question now. Here we go. I love when these pop up. You know what I should have put on there? I should have put pediatric heart surgeon. That'd be a great superpower, don't you think? We already have a couple people on the panel that are pediatric heart surgeons. Sleeping through the night, by the way, was my request. All right, so I think people are getting the hang of it now. I'm going to move on to just a couple of demographic questions. Anybody else? We have 90 people logged on now. Invisibility and flying. Too big. It's good. Okay. So first, where do you live? Let's get an idea of who's here. Remember to hit submit at the end. So far, predominantly a US audience, probably having to do with some of the time zones. Okay, we're up to about a third of the audience is now logged in. Okay, that's helpful. A little surprised, Sasha. I thought we'd get a little more turnout in Europe and in the Middle East, but this will be on our YouTube channel. You can share that with your colleagues. What best describes your daily practice? It's fun.
Mhm.
So we got a pretty diffuse audience, very much. Wonder what all the others are. Type in the chat box what the others are. I'm curious what those might be. Huh, very interesting.
Mhm.
Trying to figure out who I forgot.
Neurology,
Neurology. Okay. Thank you.
neonatology.
This will help me do further surveys. So thanks for putting that stuff in there. How'd you learn about the webinar? Just a couple more. So Grace, it looks like the email blasts are working well, a little bit more than our social media.
Yeah, this has been this way for the Mental Health Academy all the time. Usually social media reinforce and remind people to log in, and this is going to happen. But most of the people get to know about it by the email.
Okay. Age bracket. That's pretty typical for our audiences too, Grace, don't you think? It's probably representative of if I were to walk out in our ICU, I probably would see about the same distribution. Wow, everybody said their age. Look at that. Okay, so we're up to 115 of you now on gender. That ratio has been fairly consistent in the field now. I wish it was the same at the leadership level. We're getting there. Very good. And then now we start to do just a few questions to get a sense of what the baseline background knowledge of this field is. You get to choose 3 different things before you hit submit. So if you could choose the 3 most important predictors of the variance in scores, school-age children, for example, with CHD, there's the duration of hypoxemia, how long the bypass time is or how long the surgery is, low cardiac output syndrome, hospital length of stay, maternal mental health, sepsis, the use of deep hypothermic circulatory arrest, the underlying diagnosis, and fetal oxygen delivery. Shab, what do you think about that? Fetal oxygen delivery is down in the 20s, around 20%.
Yeah, maybe oxygen and nutrient delivery. We can add that.
Okay.
Or both.
Well, as it turns out that the top 3 are correct. So we'll get to that. Good. That's a good place to start. I hope this slide works. This is the first time I've used this type of slide, but you should have 7 diagnoses, and you have the option to say what's the approximate prevalence of neurodevelopmental challenges in each group. I found it very hard to slide this on my phone. You sort of had to move it around and whatnot, but you get the choice between 0, 25, 50, 75, and 100. And once we get everybody in, we're going to see what the distribution is, if we can do it. That's interesting. It's going to be, I'll interpret this, but it's fascinating.
Can the audience win something, Gil?
Yes, an extra 30 minutes of webinar time. It's fascinating. Now, again, there's a lot of individual responses here, but if we start over here at trisomy 21 atrioventricular septal defect, I guess it depends on how you define it, but that's certainly closer to 100% than what we're getting at about 75%. But this is the way And it may just be that some people voted on the wrong end of the scale, with 0 being 0 and the other one being 100. And then if we move over to non-syndromic AVSD, it's averaging out about 25%, which is probably right. It's probably a little bit high maybe, but not that close. We're recognizing the neurodevelopmental problems with DeGeorge a lot. This is tetralogy with DeGeorge, where most of the audience is somewhere around 75%, but virtually all of the DeGeorge patients are going to have some sort of neurodevelopmental or mental health challenge. And maybe Sarah, when we get to your part of the talk, we can sort of talk about that. The non-syndromic TETs I don't see on here. I don't know why. They're pink. They're probably hiding behind something, but that number is somewhere in the 20% range. Then hypoplastic left heart syndrome is here in green. The number is probably closer to 2/3 than a third. And if the panel has any different data on this or wants to discuss that, this is a very open forum. So, and then finally, total veins is actually close to 75% if they're obstructed, but closer down to about 20% if they're not obstructed. Just in terms of giving people the background information there. Any comments from the panel on this?
I think you got the hypoplasts and the transposition colors backwards.
Oh, thank you, Dan. Thank you,
Yeah.
Dan. Thanks for pointing that out. Yes, the hypoplasts are here, and that's correct. That's about a pretty good distribution. Most are mild, most are multiple, and that can put them in a difficult spot for school and getting difficulties getting IEPs. This is the transposition. It's probably a little higher than that. It's probably 50%. Dan, would you agree? Long-term, Rashad, would you agree? Sarah, when you see these patients in your practice, do you have a sense of what their underlying diagnosis is and what the frequency of those challenges are?
Yes, I intentionally target the patients and families that I feel like are at most risk. So certainly considering genetic syndromes, HLHS, and then considering also too that it can look different for the more severe. It might be easier to identify, whereas like you mentioned for HLHS, if there's more mild and multiple comorbidities, it's harder sometimes to identify and get connected to services.
Right. Yeah, thanks. Sarah's a psychologist at, I can never see Anschutz, right? So I'll just say Children's Colorado, and a board member of the Cardiac Neurodevelopmental Outcome Collaborative, for those of you who don't know her. Dan, I'm definitely going to talk to you about this one. All other things being equal, it's the important thing. For neonates with critical complex congenital heart disease on prostaglandin, purely from the brain's perspective, the best time to operate on bypass is when? Intact septum, just to be clear, intact ventricular septum. Dan, I have some of your data in my talk, and we'll get to that. But I definitely want to just ask people, let me ask the two surgeons first. Dr. Dudechem, Yves Dudechem is my colleague here at Children's National, spent most of his time, a lot of his career before here in Melbourne, and we're very fortunate to have him here in Washington. What are your thoughts on this, Yves?
I think there are data that are coming up that it's better to operate them as soon as possible, but I think it's a very little amount of data. It's based on outcomes that are not long-term. And I think there's so many things that weigh in that I'm not sure that's true. You should put in your graph 3 months or 2 months. I mean, the best time to operate is 2 or 3 months of age, probably.
Yeah, if we had a good non-bypass option, that certainly would be the case. Sasha, what do you think?
Yes, I think that again, 2-3 months is probably the perfect time. And despite of the data, it means on long-term results. I think that the clinical practice and also the type of surgery we are doing now, they make this the sense of this approach.
So I just want to be clear, in transposition with intact septum that's blue and has the potential for LV deconditioning, we would think 2-3 months, or maybe I didn't explain the patient correctly. You would
No,
still
for
wait
the-
that long?
for the-
Sasha, you once told me if you have a patient on prostaglandin, you operate the next day.
Yes. For neonates is you are telling about 2-3 months, but I think that neonates is the most how do you say, hard population of patients, because for 9 months they survive in a very bad situation with a very low pH, very low PO2, very low PCO2. So the preconditioning is there. So if you treat them in the first week of life, they will never be able to understand that they are born. They are still, with the preconditioning by the 9 months on very low pH and very low PO2. This is my feeling, I don't have data to support this. But because, our system is mostly dedicated to neonatal case, we face that, the basic PCO2 and pH by umbilical cordon after the birth is very low. So the population of patients has already a very, severe preconditioning of the protection of the brain of the body. This is what I feel.
Thanks, Sasha. We'll have some really good things to talk about. And Dan, I'm going to stop at that point in my slides, and you can share your own data better than me. But roughly, it looks like 75% of the audience would recommend operating on these kids within 4 days. PP, what happens in the Netherlands? At what age transposition and text septum?
In the first week.
Okay. Aparna, how about in London?
As soon as we can get, usually it is the second, third, fourth day. We try not to wait any longer.
Justin, what about, Justin was in Texas Children's, now is in Las Vegas.
Ideally within the first week, but sometimes due to scheduling and bed spaces, I found that it tends to be sometimes into the second week of life.
Got it. Who am I forgetting? Any other comments?
So, Gil, it also depends if you tell me if at 2 days I have a nurse that has been less than a year out of school with a resident that looking after this patient who's been for 1 year in the emergency department, and the attending is at home, and then at 5 days I have a different situation. I think that weighs in the problem too.
Yeah, certainly for me too. When the surgeon is 1 year out of training, I think about that as well. Shab, what about in San Francisco?
We try for the first week, but I think the biggest issue is just organization scheduling really affects when we can actually operate. And it tends to end up being later in the first week into the second week just because of beds. And I'm sure many people are experiencing the same issue with beds, but ideally first week, but there are some issues that are out of our control.
Yeah, that's sort of why I put all other things being equal. They never are, right?
Yeah.
There's always the other things going on. Walter, how about in Switzerland?
Well, I guess for the switch, you can wait for some days. I think the role of the pulmonary hypertension and the rush kit maneuver is also a matter of fact. And of course, I think, as the other tell, there are some logistic problems, like the weekend, for example.
Mm-hmm.
Like the what is the stuff which is available, and some resources problems also, which we have on the ICU. Personal resources.
Yeah, that's the challenge with all other things being equal, Walter. I appreciate it. It's for some reason our obstetricians like to electively deliver prenatally diagnosed babies on a Thursday, which is, Dan, I see you have your hand raised.
Yeah, I just wanted to ask how prenatal diagnosis influences, because each center has a different prevalence of prenatal diagnosis.
Yeah, these are going to be great things to talk about. It's great, pal. Jill, I wanted to be sure to get to the 2 places you've been in Texas. What's been the strategies in Dallas and Houston?
Similar to what everyone else has answered, usually within the first week, but sometimes it goes into the second.
So I guess my response to all of this is I don't know what the answer is, but that kind of variability suggests to me that we can do better than that. And I hope that we are smarter as we move forward. I think I had one more. Oh, I'm just curious, how many people on the call right now have an outpatient formal neurodevelopmental follow-up program at your institution or in your area? This was about, I don't know, 10% a decade ago. This is very reassuring. Still some work to do, and there may be more people on the call from one institution than another, but we're approaching 2/3. Made some progress. Okay, this is, we've done that one. Okay, so now I'm going to get back to, I'm going to run through my slides very quickly and hopefully give you food for thought. And that is, I think it's here. Okay, so very quickly, to think about how these issues sort of came to light and how we've all learned from this, and the younger generation would imagine that this has always been described. The basics were described 60 years ago about children having some motor problems. But what really changed the whole game for all of us was about 1975 to 85 when prostaglandin came around. And those babies with critical heart disease could now survive. And those are the patients that we're talking about now. Not the VSD that could have been repaired or the tetralogy that could have been repaired in the 70s. We're talking about those babies. And it became obvious to those in the outpatient department as cardiologists that there were neurodevelopmental delays. The field moved toward identifying the risk factors for those developmental delays. The Cardiac Neurodevelopmental Outcome Collaborative, informally formed in the early part of the 10s, was formally organized in 2016. And guidelines for follow-up were published, and I'll show you those in a second. And as I just asked the audience, outpatient clinics to identify and improve outcomes happened. If you are interested in joining CNOC, certainly look on their website. This is at cardiacneuro.org. We're expanding internationally. It's very interdisciplinary. It's one of my most fun meetings every year. So we're going to talk about inpatient interventions to improve outcomes and then move to the panel. I'm going to try, and Sarah, you know this better than me. I always get nervous when there's a real psychologist on, not just a cardiologist. This is like 30 years of work, but just in terms of the types of things that we see, it's an incorrect statement to say kids with heart disease have neurodevelopmental challenges. It's just that they are at increased risk. There are many, many kids that are absolutely fine, but about half have ADHD, 40% with deficits in social cognition or executive function, or alexithymia, the difficulty in sort of identifying how one feels. The motor problems are evident for us in the ICU. It starts with oral motor and difficulties feeding. As they turn into toddlers, it's gross motor problems. As they turn into school-age kids, it's fine motor stuff, buttoning your shirt, using a scissors, things like that. Expressive language delay is present in about 1/3. Mood disorders are increasingly common, very prevalent in the current adults with congenital heart disease operated on 2 or 3 decades ago. Oh, and by the way, I heard a wonderful webinar last night from Dr. Nadine Kasparian, also a member of CNOC and Cincinnati Children's, about mental health, and I hope to have her on the Congenital Heart Academy soon. Cognitive disability is not all that common. Autism spectrum disorder and other sensory type things are, it may even be a little more than 10%. And at least 30% of the parents have mental health challenges and PTSD. The more complicated or severe the heart disease, the more frequently are the severe impairments, the moderate or combined disabilities, and the less frequent we see kids with no disabilities. Just 3 papers I'd like you to be aware of. You can look these up when we post this on YouTube. The scientific statement was published 10 years ago now by Brad Marino and a terrific group of committee members on which children should be evaluated. And CNOC in 2019 published what those studies should ideally be, 0 to 5 on your left and 5 to school-age kids on your right. So we've described what they are, and we're starting to understand why they're happening. But now we're at the point of, can we do anything about it? And for people that have heard this story before, I apologize, but it was one of those seminal events in my outpatient career that I'll never forget. We had I think it was a 15-year-old young man who came in after a very successful repair of total anomalous pulmonary venous return. His mother excused him, and she reached in her bag and she pulled out this paper. So I saw him in about 2007. This paper was published in 2005 in JTCVS. I was one of the co-authors, and we said in the summary that in the conclusion that unrecognized and inadequately met educational needs might be a source of frustration. Some might benefit from early intervention, and neuropsychological evaluation is warranted. And the mom literally picked up the paper and held it in my face and yelled at me, not really loudly, but pretty firmly, "You've known about this for 3 years and didn't tell me. And more importantly, what are you doing about it?" And it was the "what are you doing about it" that I can still hear today, because it was fine to do our research and we got things on our CV and we presented in places, but we weren't helping anybody. You know, awareness doesn't help, just like CHD awareness doesn't help. You've got to be able to do something about it. So the first step was that we developed the CHOP. I think this was the second one in the country, the Neurocardiac Care Program. Dr. Licht, I found these 2 great pictures of you in the upper right and bottom left corner. Dan and I worked in this clinic. Dan, I'm pleased to say, is joining us at Children's National pretty soon. And this was one of the most enjoyable clinics, because you see these kids really sick in the ICU, and then they come back. But we were still asking ourselves the question, why? And we could do an entire conference. We have done an entire conference on this. But we know that fetal CNS oxygen and nutrient delivery is low. Dan has done some amazing work. The first time that I remember that we looked at this in our ICU patients was measuring cerebral blood flow. I forget the methods we used. Was it radioactive, Dan?
No, it was MRI, arterial spin labeling.
That's right. And the normal amount of blood flow is, I think, 50 grams of blood flow. No, 50 mLs of blood flow per gram of brain. I just like saying per gram of brain. And in these kids, and it was a sort of mixed bag, it was about 40% of that when we did the MRI. 40% blood flow is normal. When Dan looked at the maturity of the brain using a total maturation index, it looked as though term babies with CHD had an immature brain, about 35 weeks gestation. And we had the opportunity together to write the article, which was really the basis for this webinar, is what can we impact? How can we change things in the intensive care unit? So we know that this is a host environmental interaction, starting out from the genetics of the patient, the sociodemographics, fetal oxygen and substrate delivery. But those of us who work in an ICU can work on preoperative factors, preparing the family, figuring out the best time for surgery, which will be individualized per patient, taking care of them post-op, and supporting the family. I have to say this all the time, because it's one of those things that bothers me sometimes in the ICU, which is the notion that a baby is stable on prostaglandin. I'll move over to a paper we had published recently from Stollery. I was really in Edmonton, and I was really very happy that they asked me to participate in this project. This was looking at fetal patients with hypoplastic left heart syndrome and comparing them to controls. And we looked at patients who, even at 6 hours of age and then 24 hours of age, the control patients had a combined cardiac output here, but the children with HLHS, because the single ventricle has to pump 1 or 2 cardiac outputs, the volume of that blood goes up. But despite that, the systemic blood flow goes down. And we've all seen that, but it was interesting to see the severity of this. So a normal systemic blood flow is up here in blue. So these are our babies measuring QS, or systemic blood flow, with hypoplastic left heart syndrome. And you can see they're dramatically lower than normal. And many times the babies will, for me as an intensivist, I would say, the kid looks okay. The SATs are 92, but he's not tachypnic, not tachycardic. They're really pretty much on the edge for their total body flow. You can see the same in your upper right for brain flow. And we'll talk about that in a second. They get necrotizing enterocolitis. Is it because their gut flow is down? Maybe. And we do know their pulmonary blood flow is increased, so-called overcirculation. So here's our brain. This is your brain. This is your brain with hypoplastic left heart syndrome. And you can see that you start out with a low delivery of oxygen and nutrients. So to say that a baby is stable on prostaglandin makes us feel better when the vital signs are okay. But systemic perfusion is always unreliable with an open PDA. Always. The neonatologists have known this in babies with structurally normal hearts with an open PDA. We know kids with ductuses get heart failure. Superimpose that on congenital heart disease with a fall in pulmonary vascular resistance. And you can imagine that this physiology during the transitional circulation is a window that I think we can make a difference in. Dan has this wonderful, and this is a paper Jennifer Lynch wrote, Dan, senior author. Dan, do you want to explain what that device is on that baby's head? Would you mind?
Sure. It's basically fancy NIRS. It uses frequency domain, which means the light is modulated at very high frequencies. So that allows us to be able to identify our light versus ambient light better. But because it's frequency modulated, you can also measure things beyond just absorbance changes. So you can measure the shift in the modulation, which gives you a phase change, which allows you to measure scattering. And scattering can be used to measure how scatterers move through the tissue that you're over. The things that move that scatter light are red blood cells, so it gives you a measure of cerebral blood flow at the tissue level.
Great. So it's like NIRS on steroids.
Yes, it's $150,000 NIRS.
Okay, thanks. And then this was my take home from this, and I hope we have a chance to talk about this later. We know that cerebral oxygen delivery falls each day, surgery is delayed, and oxygen extraction fraction, the oxygen extraction increases. But does this translate into important longer term issues? We don't know, and have to be balanced against all the other things that we talked about. I'm going to talk about just two other things. The first is duration of CICU stay. This is work now 20 years old from the Boston Circulatory Arrest Study, where if we divided the 166 patients with an arterial switch operation into quartiles, and this goes from about a 3-day ICU stay till about an 11-day ICU stay. The longer one stayed, the lower the verbal and full-scale IQs were statistically. And the statistical analysis, which if you looked at things that made you stay longer, such as sepsis, or things that dropped your IQ, such as socioeconomic status, it still was predictive of worse outcome. And leading the outliers for each day, the 5% of the outliers, for each day in the ICU, there is a 1-point fall in performance IQ, 1.5 points in all of the others. So this is a real phenomenon. It's one study. It's the circulatory arrest study. It's the way we took care of kids 20 years ago. So the question is, actually 30 years ago. So the question is, where do we stand with that now? This is the same sort of thing. The longer one stays waiting for a transplant or in Norwood, the lower the IQ. I'm not going through all of these different studies. Walter published this stuff comparing hybrids and Norwoods, but every single neurodevelopmental paper that's out there, increased length of stay is related to it. Why? It's cumulative, as we talked about. Some of you have seen this before. Our nurses are great. We have filters, but we don't always get these air or particulate matters out for children that still have a right to left shunt. That stuff can go right from vein to brain. What about other cumulative exposures? All of the stuff we use are made of plastic to keep it soft, from Foley catheters to IVs to umbilical lines. And then, of course, the exposure to bypass. This is from a general PICU, not from a cardiac ICU. But phthalates, which is one of the breakdown products of plastics, have been associated with learning disabilities and ADHD. And when this group was followed up after PICU discharge, 50% of the ADHD risk was associated with the ICU phthalate levels. And then in the SVR trial, Alan Everett and Eric Graham looked at another breakdown of plastic parts, which is cyclohexone. It's everywhere. And babies in the ICU, just those preoperative babies, have a measurable decrease, but it increases massively after exposure to the tubes and bypass. And the higher serum cyclohexone levels were independently associated with lower scores at a year. And again, the predictive validity of this is minimal for long term, but we're starting to tease out things that may be modifiable. This is a relatively old study that we did at CHOP, looking at what was associated with white matter injury. We used artificial intelligence with the guys from Villanova. And it was common practice at CHOP at the time that kids would come back from the operating room very hyperventilated after their Norwood. Part of that may have been bagging in the hallway, and I have no idea what CO2s do when we bag patients in the ICU for brief periods of time. But when we did this node analysis, the combination of diastolic hypotension and hypocarbia less than 30 was 100% predictive of new white matter injury. These are modifiable for sure. Other things we all know about sleep, staff interventions average 4 hours, plus or minus 1.5 hours. Sleep was present only in 3%. Melissa's going to talk a lot about this when we get to the hostile environment of the ICU that we have. So as we start to look and tease out, why is longer length of stay an issue? Well, some of it may be cardiac, but the longer they're in the ICU, they're more likely to have abnormal hemodynamics. They're more likely to have sedatives and pain and anesthetics and chemicals and noise and all the other things that go along with that. And it's one of the key factors related to parents' PTSD, which we have started now to address. I'm going to run through this quick because I asked so many questions to the panel. I'm running a little bit behind, but roughly a third of people, mothers more than fathers, have re-experiencing and numbness and disassociating when they come back to the hospital for follow-up visits. Again, what are the things we can modify? Longer length of hospital stay, lack of social services involvement, clearly modifiable. Patients that come from a distance. And in this study, there weren't many people who were, that all spoke the same language, but I can tell you that at our place, where we have a significantly prevalent group of patients that are Spanish speaking only, as well as a smaller group that are Arabic speaking only, I wonder how that relates to the type of communication and stress the families go through. So again, these are modifiable. You can imagine sitting in the ICU, waiting for your baby to have surgery. This doesn't look like it wants to come on. And watching them retract and not look particularly healthy. Seeing the pumps prepared for your operation. I just can't imagine the fear of families handing their baby over to the surgical team and seeing them walk down the hallway. Being in the ICU is very challenging, more frequently for mothers than fathers. Every time I find a picture of a dad in the ICU, this is what I could find. But they go off for tests. Some of the older style ICUs are just jammed and very hard to not pick up on things that go around you. If somebody has an urgent or a cardiac arrest, imagine being in the next bed space and think that might be your baby. So this is a very scary environment for families and an area that we can certainly improve on. It's one of my favorite memes when you pull lead off the baby and all you see is a flat line, especially those families who just come in. So this gets back to one of the questions I asked at the beginning, and one of the strongest predictors of adverse neurodevelopmental outcomes is maternal mental health, maternal worry, and that affects independently the baby's neurodevelopment. So improving how the family does also improves the baby. Okay, so we know that these are all the things I've been through, the cumulative and multiple things that happen in the ICU. So how do we do anything about this? Where do we put our emphasis at this point? I think there's a big opportunity in family stress, which Melissa will talk about. If I had to pick one thing that you can all go do today, is to start thinking about ways to reduce length of stay. That's safe, of course. Take the stuff out. It may not be a good idea to leave a plastic tube in an extra couple of days. I don't know, but the data would suggest it's not a good thing to do. Move the patient through the system as quickly as is safe. Rethink the benefits of, well, maybe I'll just stay intubated over the weekend. Less plastic exposure, take that stuff out. You don't need to use as much analgesia. You have a less risk of an infection, shorter period of family stress. I think in neonates who require surgery with bypass, operate as early is safe, but that's shortly will change and is up for debate. Consider non-bypass alternatives like we're doing now with early pulmonary artery banding prior to a delayed Norwood. Recognize that hyperventilation and alkalosis is as bad as acidosis, and provide individualized neurodevelopmental support for the baby and the family. I'm hoping Amy talks about this incredibly important paper that not only was taken from her years of experience getting this implemented in Philadelphia and then expanding it throughout the country and the world, but I think she should and is very proud of the AHA scientific advisory statement that came out 3 or 4 weeks ago, specifically talking about what is indicated and what needs to be done from the AHA. And Amy Jo, congratulations on this. It's just a terrific body of work. Then one last thing I'd like to say has to do with the medication burden. It's not uncommon we send these patients to the floor on 12 medicines given 3 times a day, things they needed, but when a baby is sick and we take away that maternal role of feeding and you have to give medicines 5 times a day. A mom sent me this picture for a few days of medication delivery. I have trouble giving my kids amoxicillin 3 times a day. So to summarize, what we do here makes a difference here. We have a great opportunity to improve stuff. I want to introduce my colleague, Melissa Jones. Sasha, I know you'll remember this picture. The Congenital Heart Campus, which was in Ortigia, Sicily in 2019 and was started in 2017, I think, in Taormina. This was the underpinning for the Congenital Heart Academy. And when COVID hit, we had to postpone all of our in-person meetings, but I can't wait to get back to Sicily. Melissa is shown right over here as advanced practice provider. And as my parent told me back in 2007, she's going to answer the important question about what are you doing about all of this. So I'm going to put your slides up, Melissa. Hold on.
Do you want to just stop your screen share and I'll share mine?
Can you do it from there?
Yeah.
Yeah, okay, great. I'm going to while Melissa's pulling up her slides, any comments? Catherine, I'm glad you were able to get on. You've been imaging these babies and you were involved in these babies early in your career in a completely different role. Do you want to tell the audience how you got into this and where we're going from here? This is Catherine Limperopoulos here at Children's National.
Sure. It's great to be here. Thanks, Gil. I got into this as a therapist. I was an occupational therapist in the 90s, working in the neonatal ICU. This is where we took care of newborns that were with critical heart disease that required open heart surgery. And I ended up getting involved in really understanding the outcomes of these babies now for over 2 decades. And the way I got involved was because I wasn't involved. And as a therapist, we would see just about everyone in the neonatal intensive care unit at the time, except for babies with congenital heart disease. And when I asked, it was because at the time, so we're talking over 2 decades ago, the response was because we don't need it. At the time, this was never identified as a need, and so we changed that paradigm by beginning to do some graduate work and trying to really understand whether or not this population was at risk. And at the time, again, if there was any concerns around risk, the focus really was on the perioperative period, or I should say the intraoperative period. And that's how we began to access these babies from a neurodevelopmental perspective. It was really those that that top 5% that either had intraoperative complications and ended up having seizures, and these babies ended up getting referred to for early intervention, PT, OT, speech, postoperatively, or stroke, seizures, etc. And that really formulated the focus of my work, where we began to ask some critical questions around, there's a proportion of these children that undergo, that suffer injury, a neurologic injury intraoperatively and or postoperatively. But really the lead question, and really what started my work, was whether or not these newborns are sort of normal, neurologically intact before surgery and in that early postnatal period. And that really began the focus of my work. And maybe I'll pause there and hand it over to Melissa.
Thanks so much, Catherine. It's such a great opportunity that we have to start before birth, go through the ICU. And I think that's actually where Melissa's going to start from. So, Eve, I saw your hand was up. Before. Did you want to add something here?
Yeah, it was just that, about your question, specifically for TGA, we had debate in Melbourne about the best timing. And some of the surgeons wanted to do it in the first 48 hours, and some were adamant to wait for a week. We looked at the data of ICU and hospital stay, and there's a series of more than 900 patients regularly published, and there was actually no difference. So the patients who were operated earlier were staying a bit longer in ICU. So the total number of ICU days and hospital days were very similar. Didn't make any difference. So you can take it one way or the other.
Yeah, that's terrific. It shows sort of non-inferiority of either approach. And the question is going to be what happens later. I mean, if operating earlier was riskier, then we really are in a difficult situation. And I know that's the same as the group in Kiev, in Ukraine, where they operate in the first 24 hours. All right, Melissa, I'm talking too much. It's up to you.
Okay, you can hear me. Oh.
Please hold people. Are you still echoing?
Yeah.
Oh, man.
Okay, I think that's good. All right, great. Okay, so thank you so much, Gil, for inviting me to present about our program. I will sort of tell the story of how our program got started and how we've sustained some changes over the past about 6 or 7 years since we got started. So what happened in late 2016, early 2017 is I looked around and I felt like we had a very strong Developing Brain Institute, fetal diagnosis program, and our CAN-DO program, and which was our neurodevelopmental follow-up. And I thought, well, what are we doing in the CICU? This is our opportunity to really think about the messy middle and how we might be able to influence change, not just in the short term, but in the long term. So we pulled together a group of very motivated and enthusiastic therapists to start. And at the time, there was already a very strong collaboration between our cardiac surgery team. And so the neurocardiac critical care team really brought all of those stakeholders together. I had the very fortunate opportunity to work with Catherine Lambropoulos to really help get this program off the ground. We met regularly, we met with each of the stakeholders. We really tried to elevate the expertise that was here in our unit. And I think when I look back at how one of the reasons why I found this to be a success, I think this has been a successful program, is that we really carefully evaluated where our strengths were and what we could capitalize on at that time, and then begin to really build practice changes, research, and education. So to start the program, we conducted educational sessions in all different forms. So across the Heart Institute, in nursing specific meetings, in the fellow meetings, we talked a lot about the risk factors associated with being a patient and a family in the cardiac ICU. And one of the key parts of these education sessions was that we embedded a piece of it to be reflective of our own practice. So we really wanted people in these sessions to reflect on, well, what can I do to make things better? And we collated all of that data. And that is what helped us to prioritize the direction that we would take in terms of clinical practice changes and research. I'll use one example of a project that followed in this sort of framework. And one of the themes that we kept hearing in our unit was there was a huge discrepancy in how we manage pain in terms of the medications that we use, the amount of medications that we use. There was recognition that our patients who were chronically critically ill were amassing an enormous amount of drug accumulation. And then we also noticed a huge discrepancy between nurses' comfort level in allowing families to hold their children. So we went to the literature and we found at the time the individualized family-centered developmental care paper that Gil showed that Amy Jo and colleagues had put together. And that really helped us to focus on what sort of tangible changes we could make in our unit. And from that, we developed a comfort curriculum. And that comfort curriculum focuses on three major interventions. One is a standardized sedation pathway that both prioritize, that is nurse driven, and so reduces inconsistent practice. And it also is, it focuses a lot on how we come off of the medications, not just how we escalate them. And then while we're coming off of medications, we want to try to involve parents more. So the second part of the guidelines is the infant and toddler holding guidelines. So that helps, we built consensus around who was safe to be held and when. And then for those who were not able to be held, the guideline calls for positive touch by parents. One of the interesting things we found when we rolled this out is that the chairs we had in the unit were not appropriate for parents to be able to provide positive touch. So we changed the chairs in the whole unit and got some stable and comfortable chairs where parents could just sit up next to the warmers and provide positive touch to the babies that were not able to be held. And then the third piece of this is our non-pharmacologic support reference table. And so we have the packet of these three pieces of the comfort curriculum at every bedside, and it's embedded into all of our education and our onboarding in the cardiac ICU. That has led to some research, and we're now writing up our findings, which I can talk about in a bit. But I think our ultimate goal through this program is to really impact culture change and to change the way we think about patients and parents and caregivers in the cardiac ICU setting. So let's see. So this is one of the slides that I use when we talk about, when I talk to the new staff in the cardiac ICU, and it's really to draw attention to the huge difference between the developing brain at home and the developing brain in the ICU. And so we actually go through all of the different things. Like there's eye contact with the dad in the upper left corner. There's skin to skin with the parent in the right corner. I think that, really calling these differences out has made a really big impact on the way our staff thinks about what's happening in the baby's brain and the huge differences between being at home and being in this, as Gil called it, a hostile CICU environment.
For many reasons.
Yeah, for many reasons. So the our ultimate goal is to minimize the negative effects of the environment and to maximize neurogenesis and healthy family bonding. Our goal in terms of areas of impact, we wanted to impact the environment. We wanted to make sure that we had the full team on board. And we wanted to make impacts on, of course, the patients themselves, and then, of course, the families. We presented our program recently in Miami at PCICS, and this is our vision, mission, our goals, and some of the strategies that we have developed. I won't read them out, but you can see them. Over the course of the years, we've really brought together our full team. So we are closely, have a very close partnership with our neurology colleagues. Sarah Schlauer is the director of our neurocardiac critical care program with me, and we are. She has really helped us to standardize our neuromonitoring guidelines. She now runs a huddle in our cardiac ICU every week to just review the neurologic findings of all of the patients that have had them. Our surgeons are very much aligned with this program, Dr. Dudicam and Dr. Munoz, and of course, Gil has been a big source of inspiration for the whole thing. And then Catherine and her team continue to support our program in a number of ways. And then the fetal heart program with Mary. We recently had a retreat where everybody's sort of doing all their work, in their own little departments and divisions. And then we all came together at a retreat a couple of months ago and presented all the work. And it's really impressive what I think we can accomplish together. These are some of the clinical core goals. Right now we have the ability to do real-time neuromonitoring. So we're looking at T3 and EEG in the command center. And like I said, our neurology colleagues are very much embedded in the CICU. These are some of our selected publications over the past several years. We presented our data about the comfort curriculum, where we were able to reduce pain scores, reduce some opioid and benzodiazepine exposure as well. And then we also looked at, this was a really fun study to do. We put decibel meters in each of the rooms and measured noise and compared it to the EPA and the World Health Organization recommended outcomes. And what we found, we measured 64 patients over the course of 5 weeks. We got sound levels every 5 minutes. So we had a ton of data, and we found that our average daily noise levels were around 50. The maximum were about 77. And there was a impact on noise levels in terms of the blood pressure and the heart rate of patients. So this is our cartoon, which we all really love looking at to help us determine what is safe. So this is where the World Health Organization recommends patients in the hospital are what they're exposed to. And then it's not so much the average levels that they're exposed to, which is here, but it's these outliers that are particularly worrisome, because what we found is that that's where we have heart rate and blood pressure increases. And then we also found that there is there's increased prediction. The noise levels predict an increased need for sedation, which again is very worrisome given the negative effects of opioids and benzos on our patients. So we've got some ongoing research, which is very exciting. And I think as we continue to build our program, we're mindful of keeping our foundation of our sort of neurodevelopmental rounds and our cohesive team to help really optimize our outcomes in the long run. So we, in summary, have recognized that there is certainly a role for the CICU to impact the neurodevelopmental outcomes of our babies and really the mental health, I think, of our parents as well. We're on time. Okay. So neuroprotection, is it possible? Can we do this more and help the babies and moms? We feel like the parents are the best buffer to the babies to protect them from this hostile environment.
Oh, I should mention this. So
this is
David was the third patient enrolled in the Boston Circulatory Arrest Study in 1987 or 1988. And he and I have stayed in touch. Ironically, that's his baby, held in exactly the same position, who's heart healthy. And this is our goal, right? In the ICU, our goal is not transfer to the floor. Although many times I hear that in the ICU, that our goal should be, let's move the kid, transfer to the floor, and then we forget about it. That's when the hard work has to continue, because the goal here should be healthy families able to deal with the stresses of life, contributing to society, and having the next generation. So why don't you close that?
Okay.
We actually stayed on time. So here is the fun thing I wanted to try to do, and I really want to thank the panel for being part of this. I asked the panel to think of a few things based on their own experience and what they've just heard, actually. And I asked them to answer 3 questions and asked them to try to keep it down to 1 or 2 minutes if they can. It's hard, so that we can have a healthy dialogue. And what I've asked them to think about is, what should we start doing? What should we keep doing? And what should we stop doing? To me, I'm going to start, and Melissa's going to go, and then we'll go from there. So what should we start doing? It's hard to know, because the level of where we start at in our neurodevelopmental care is very high in Philadelphia, is very high in Boston, is very high in Washington, and probably many other places. So the first thing that I would say that we have to stop doing is having our trainees talk about the neurosystem when they sign out the neurosystem as what sedatives the patient is on. That's not the neurosystem, that's what sedatives the patient is on. We have to start thinking about the brain as much as we think about acute kidney injury and how the heart is doing, of course, and whatnot. So we have to start thinking about the brain as an important organ system at every single level. And I'm not sure we all do that in the ICU. What should we keep doing? Collaboration. The fact that all of us are on here, no single center is going to answer any of these questions. If we want to answer that question about transposition, we all have our biases. I'm glad that the answer came out like I thought it would. And we'll learn what's the subgroup that are better early, what's the subgroup that are better late. And the only way that we do that is to share data. And then what should we stop doing is being conservative. We work in ICUs, and by that I mean how long you keep an extra IV in, all the way up to how long you keep a child ventilated. We really should stop thinking about the fear that a kid might do badly based on our action, and be prepared to reverse it. If we don't wean medications, if you can, stop them. If you have to put them back on, put them back on. Don't go very slowly with the ventilator. Turn it down and extubate the patient. The worst that can happen is you've got a team that can reintubate. So for me, it's getting everybody to move through the system fast. Melissa, I think you're next.
Okay.
And I was on your
I think you're on my mic. Okay, good. Okay. Okay.
Could everybody hear me? Because it was really curls.
He projects. He projects. Okay, so I have for start. Are we starting with start? I'll start with start. Okay. Okay. I think we need to start thinking about ways to promote bonding for families that cannot be at the bedside. So we have a lot of parents with different sorts of resources, and I think that we have to find ways in our ICU to help support parents who are not able to be at the bedside. I think some of the ways we're thinking about are using voice recordings to expose them to the family's voices, having parents read books into voice recorders, and then a scent exchange with a mom's t-shirt or something along those lines. But I think that's a real challenge for us, and we need to start sort of thinking more creatively about that. Something I'd like to stop doing is finding reasons not to hold babies. I think that there's a million reasons. Thanks, Amy. I knew that would make you happy. I think there's a million reasons,
girl.
not to hold babies in the cardiac ICU, but there's more reasons to hold babies. And as I said, the way we talk to our families about it is that they are buffers for the toxic environment of the ICU, and the ability to hold them has so many benefits that Amy has written about in a bunch of papers. But I think that it's beneficial, obviously, for the baby and for the mom. It gives the parent a little bit of their role back. So I think we have to stop finding reasons to not hold babies. And then what I'd like to keep doing is, because I've learned so much through building our program, is I'd like to keep building cohesive teams. I think that there's so much expertise all around us. We need our psychology colleagues and our therapists, our child life specialists, because really the outcomes we want are not something that we as nurses or physicians can deliver alone. So I think that that's what I'd like to keep doing, is building up these teams.
Thanks, Melissa.
Okay, I'll take it from mine now.
Am I on without an echo? Okay.
Yeah.
Shab, could you just give a one-liner about what you do, where you are, and then maybe answer those questions?
Sure. I'm Shab.
You're muted, Shab.
Am I still muted?
Maybe it's my mic. Hold on.
Okay.
Everybody hear Shab? Yeah,
Yes.
okay, it's me. Go ahead, Shab.
Hi. So I'm Shab Pavandi. I'm a pediatric cardiologist here at UCSF, Benioff Children's Hospital, and participate in a lot of clinical research around neurodevelopment in congenital heart disease. So my answer, so in terms of what I think we should, and I mostly do fetal cardiology, which is going to explain one of my responses, but what I think we should continue doing is continue increasing prenatal detection of complex congenital heart disease. We know that it does make a difference, and from a brain perspective, there's been pretty good literature that it's beneficial to have prenatal detection of, neonatal forms of congenital heart disease, at least like transposition or hypoplastic left heart syndrome. I think the second thing we need to continue doing is this concept of efficiency through the neonatal hospitalization, kind of to your point, Gil, of reducing length of stay. And there are, really great learning networks through PAC3, PC4 that are focusing on these efforts to try to improve efficiency and move patients through, like removing chest tubes and things in a timely fashion. And then third thing we need to continue doing, which is, I think, really important, we need to continue supporting this research, advocating funding agencies, et cetera, to continue funding this type of research. Because I hear a lot that we've done all the research we can in this area and we know everything we need to know, so we should move on. But clearly that's not the case. So we need to continue supporting this direction of research. So I'm going to throw out what I think we should start doing, and I'd love to hear what others have to say pretty specifically regarding the use of brain MRI in neonates. And I feel that I've come around to that it's potentially a useful biomarker to have brain MRI imaging in neonates at least once postoperatively before they go home, to have information on expected, at least in part, expected outcome. And at least in our case, from our research perspective, it's really helped identify those at risk for worse developmental outcome, and it helps plug them into regional centers more efficiently than if they don't have the brain MRI. So I'd love to hear what others think about that as well. what we should stop doing, I think, is related to what Melissa said, is kind of being in our own little silos. I feel that CNOC, as a good example, has really brought together people from lots of different disciplines. And it's been really great for me to connect with people outside of cardiology to really understand this most common morbidity that our patients face across the lifespan. That's it. Did I keep it under 2 minutes?
You're muted, Gil.
I'm unmuted. Go ahead.
Shad, that was perfect. Thank you. Catherine is next. You've already heard a little bit about her work and seminal work on fetal cerebral blood flow in the fetus and delay in brain maturation, and is working in the fetal developing brain lab. What should we start, stop, or keep doing, Catherine?
So I think we should keep building bridges and partnerships, and seeing the parents as a partner in the work that we do from day one and beyond across the lifespan. I think that we need to stop using MRI only to identify brain injury and start leveraging MRI as a way of assessing brain health. And we can talk more about that. I think we need to really, just because a brain may look structurally normal, doesn't mean that that's going to equal a healthy outcome for a child. So I think that's important. So did I do start or stop? We need to start. What we need to stop is what I did. And I think what we need to start to do is bring the brain at the level of the heart and make decisions about the heart while being informed about how we support the brain. So I think I really wanted to keep it short, but perhaps some of these statements may be somewhat provocative and there may be opportunities to discuss them further.
I hope so.
You still, are
You-
open?
I'm open, yeah.
Okay. Just as a reminder to the panelists, there's some questions that we can answer and type answers in. Thanks, Shauna and Jenny and Kelly. We'll get to those shortly. I'm glad you're not in, I don't know if I'm glad you're not in Vegas, Justin, but I'm happy for you that you're in Cabo. What are your thoughts? Justin, are you director of the unit at Sunrise Children's now?
Correct, yeah.
Yeah, so Justin's a cardiac intensivist, very active in this area, is now in Las Vegas at Sunrise Children's. Why don't you can either start with stop or stop, whichever one you want to start with, man.
Yeah, so I think one thing that I'd be interested in starting to do a little bit more is there's so much focus on the negative neurodevelopmental outcomes, rightfully so, but if there's an opportunity to look at patients who are doing really well and try to look back and see what went well and what did we do, there's obviously going to be a lot of patient and family factors related to that, but I think that I would encourage us to kind of also look at these, take kind of an appreciative inquiry approach to this and start to look at the patients who do well to see if we can come up with, why things went well for them. As far as things to stop doing, I think it builds on kind of what we do in rounds and what Gil, you were talking about with the kind of neuro system being sedatives. I think that we need to stop sort of excluding families from rounds or just making them all so medical. And I think, as part of the neuro system, it might be really including how can the family interact with their child today as we're moving them along through there. And there's work, that Erica Sood has done with the care partnership pyramid and other things like that, that I think would be potentially really helpful to incorporate a little bit more and then keep doing, maybe it's start doing, but I think that it's sort of reframing and continuing the research into not really accepting just any longer mortality as an outcome or these composite morbidity outcomes, but really insisting on research going forward to look at a little bit more holistic outcomes for the patient, for the family, and how they're doing going forward to really define which centers are doing this excellently.
Eve. I feel like I'm in the echo lab. Get it?
I'm unmuted.
Eve, you and I talk about this quite a bit, and I know this is a particular interest of yours. From the surgical perspective, as well as a research perspective, what are your thoughts on where we need to start going and stop doing, et cetera?
Okay, so I'll give you my point of view. I think we should stop counting points and say, okay, oh, it's horrible and so on, and what are we going to do? And you have congenital heart disease. And we should start some actions. We should stop being focused only on Bailey score between 2 and 4 years of age, because that doesn't help us. We need much more longer term perspective and something that is a little bit more clever than just this Bailey score. I think we should keep working to find out the real cause of the neurodevelopmental outcome impairments that we see. And I think about, with the tools we have, we can get better understanding. I'm working on some idea with a combination of NIRS and lactate. There's a guy working now in our command center looking at vasoactivity of the brain. I mean, I don't know if you know, but systematically, you put a patient on bypass, the NIRS increase over time. Same flow, same oxygenation, same concentration of hemoglobin. But during the hour of cardiopulmonary bypass, you go from 60 to 80. I don't know why, but there's something that happens during cardiopulmonary bypass, so we can understand more things. What we should start doing is we should start intervention. We have our thoughts. Now is the time. Now is the time let's get an idea. Melissa do something on environment. We have an idea about the timing of surgery. Let's study it prospectively. We need the data. And also for the intervention after surgery. I mean, I don't know if you know, but when I asked Jacqueline to see the impact of the intervention in the CAN-DO, I mean, in literature, there was about four papers showing the impact of intervention on patients having neurodevelopmental outcome impairment. And only one showed the benefits. So we have to work on what's working to make this patient better. I have one question. We're talking about the psychological environment. And I have no doubt that we need psychologists at all time of the care about hemodynamic parameters. You haven't talked about genetics. What's the knowledge? I mean, if you have congenital heart disease, is there something genetically that determine you to have a bad outcome or not? Have we changed that? I don't know. It's a question. Thank you.
Eve, thank you for those. So we'll go to our other surgeon, Sasha Gatti, in Taormina Hospital Bambino Gesù. Tell us a little bit of your thoughts.
No, what I think that probably we start to do to make a sort of point of care, what is the basic evaluation before surgery, not after surgery. Because before surgery, probably we can know, we can show something interesting. After surgery, I think that the damage is done and you don't know, and it's very difficult to understand if it was before or after. So I think that we have to start in our system probably to establish a point of care for, as Katerina said, heart and brain are the same, must be matched the same. What I think, I really like the example, that we have an example about the impact of the family on the development of child is in Down syndrome. In Down syndrome, you see how is different type of development of the child with the same syndrome. We have child that are able to write, there are child that are very aggressive, they are completely different. So I think, as I understand, that we have to keep working on the family and remove the fear from the family. What I would like to stop, we have to stop to anticipate the symptom of the child. We have to wait. The congenital heart disease needs to be treated when they need it, like prostaglandin, Ruskin, you know our position about this. So what I think that we have to wait symptoms. Don't touch asymptomatic neonates.
Thanks, Sasha. Pleasure to introduce Dan Licht, really one of the giants in the field. We've been to Eagles games together, good friends. I'm so glad he's coming to Children's National. He's a pediatric neurologist who's been involved in this patient population for a long time. I'm really curious what you have to say, Dan.
Well, so many things go through my mind. I think the most important thing that we have to do more of is informing parents. Have them understand what the road ahead looks like, what they need to be paying attention to. The ICU stay is all hills and valleys. They need to know that a resident, attending, nurse will say something that sounds particularly bad and isn't, or conversely say something that sounds particularly good and isn't. And that the true knowledge of where things stand isn't really understood until discharge or after. This helps parents emotionally to sort of stabilize themselves, and that's going to be very important once the child gets home. In terms of what we should do less of, that's sort of hard for a neurologist that comes in for consults and isn't really in charge of the baby, is just a sort of kibitzer. The things that I think are important when we consider oxygen delivery in the brain, I think we really have to get a better understanding of the impact on oxygen delivery in everything we do. Sickbay has an algorithm that they're working on and hopefully will be commercialized soon, called Patient Monitor. And this is a way to sort of phenotype your patients based on their diagnosis. For each patient that you enter into sickbay with the primary diagnosis of TGA.
Dan, I'm sorry to interrupt you. Could you explain to people, especially international, what sickbay is?
Oh, sure. It's a vital sign capture device, much like ediometry and several other devices. Sickbay is sort of I would call it the Rolls Royce, probably both for its cost and for its capabilities. But it'll capture data off of any electronic device in the CICU that has a data output on it. It'll capture it at its native frequencies, and apply a timestamp to it. But basically, it works with your medical record system so that every patient that is entered is categorized by their primary diagnosis and develops a trajectory for that patient, and then compares that trajectory to all the other patients that you've admitted previously. So it sort of phenotypes the patient and tells you where things are straying or not straying. So that's a very interesting concept and something I really can't wait to see in action. In terms of the surgeries, I don't think it's the place for a neurologist to say, bypass times have to be shorter or use DHCA versus antegrade cerebral perfusion. I think we need to know more about both of them. But I think the surgeon has to do the surgery that they're most comfortable with, do it as quickly as they can, as safely as they can, and don't leave residual shunts. And that's about it for me.
Thanks, Dan. Aparna is joining us from London. Maybe let everybody know what you're doing, what you're working on, and what are your thoughts on the panel and the questions.
Thank you so much. My answers will reflect where I work. I work in a big cardiac ICU, but within the context of the Nationalized Health Service. So we don't have the luxury of what you have, that is a cardiac neurodevelopmental team available to you. So we have to develop the best or do the best for our children with what resources we have. The one thing I'll say, what should we start doing? We should start doing, I think, neuro rounds. And I call it, like, in simplistic words, a neuro rounds. But what I think is that we should start thinking at the bedside in the cardiac ICU, what are we doing to assess this child's brain? What are we doing to support in the, from whatever information we have so far, and what we can do to keep that, without other interference from medications, sedative drugs, etc. I would like to wake the child up more. I'd like to start early rehab. Rehab doesn't have to be after the child's being discharged. You can do physiotherapy in the ICU. I think we should do these simple things. We should get our residents to examine the patients and assess their neurology. Yes, agrees. It said, saying the patient is well sedated is not the right thing. I think we should also start thinking of engaging parents right from the very start. And I think well-coordinated care. I don't want my cardiac ICU patient to be exposed to the vagaries of the system, the scheduling system, or the child having been presenting somewhere in a state of shock and then coming to the ICU. I'd rather have a well-coordinated, a proactive care pathway for all these children, and to integrate the brain throughout the assessment, the monitoring, the rehab. One thing I also feel is that what should we keep doing is, I think, reduce the ICU length of stay. But we always focus on high-risk patients, but that's assuming that there is a high risk and the others are low risk or no risk. But I think there's a lot of silent neurological injury that happens, and this is a hidden morbidity. It can emerge much later. So it's not, you cannot identify your neuro outcome as, okay, the patient's discharged now, or is walking, talking, seeing. I think there are lots of issues of executive functioning which does not get picked up until very late. And one of them I focus a lot on is memory. And, it's from research that we did in children with TGA who had switch operation, and they were assessed between 8 to 16 years of age when they were going to mainstream school. So by and large, they were well children. And we identified that they had lots of significant memory issues. And, memory can affect in multiple ways, and a child's academic attainments and, being a part of the society, integrated within society. So that, I think we should, we should sort of, keep doing, is that, think of children as being at risk all the time throughout. What should we stop doing? I think we should stop being very cardiac focused. I think we are very cardiac focused, and I think we should start thinking of the patient holistically, the brain, the neurological outcomes, the neurodevelopment, right from the beginning. And definitely, I would say from an ICU perspective, we should, stop sedation and get these children awake and out of the ICU faster. Thank you.
Great. Aparna, thanks so much. And I didn't think about sort of the differences that the overlay of the NHS brings. Really happy that Walter Knirsch joined us. Walter, tell everybody what you do. I've seen a lot of your work imaging, but maybe you can sort of give a slightly different perspective. Thanks.
Yeah, thank you. Well, I'm a pediatric cardiologist working in Switzerland, and since 10 years, my research focus is on neurodevelopmental outcome of those children. And regarding your questions, I think for me, sometimes we are treating a black box, like a preterm or a term newborn, with all the medication, ventilation strategies. And I think we should start on better understanding the pharmacotherapy we do every day. We know that the doses we give are somehow calculated from the adults. And I think the understanding of the metabolism and the effects of sedative medication, what Melissa told us, is really has a relevant impact on the neurodevelopmental outcome of those children. When we know them, they have been sedated for a week at the ICU, and then they leave the ICU. We sometimes lose 2 weeks when we withdraw this medication. So this is really a problem, and I think the idea to shorten the hospital stay or the stay at the ICU, this is good, but the things go on afterwards. So I think pharmacotherapy, knowledge about pharmacotherapy, that would be really needed, I think, and even to find good doses, looking at the side effects. What we should keeping doing is, well, we do a lot to optimize perioperative care. And we have the discussion before, including the timing of the procedures which are needed. And I think most important is their invasiveness immediately after birth. And so sometimes I think there can be some advantages in looking at some stepwise approaches. Like Justin made the question in the chat regarding a temporary banding, for example, for a hypoplastic where you have a pulmonary overflow before we do an early stage 1 normal procedure would be an example. And I think what I learned here in this session is the impact of all those psychosocial factors, what I would call parent mental health. And I think the long-term support of those families starting during fetal life by accompanying these families seems to be, for me, quite important, so that you have a person within who is taking this road after the early diagnosing during fetal life, and then accompanying them directly at the ICU when they are really in trouble. And I think this could be also a way to optimize this treatment. I think there's a lot of impact. And what we also could discuss is neuroprotective medication during surgery, before, after. There have been some studies. And for sure, this is always interdisciplinary. And I think we should stop doing some single center approaches. And I think this webinar today is a very good example. And I think the meeting in Washington in summer is also a very, very important initiative, that we share our data, that we try to come worldwide more together to do collaborative research. That's my thought about this.
Awesome. Awesome, thanks. I'm looking back at our model here. So many different views, but they all sort of come together. Grace, who's one of the co-founders of CHA with Sasha and myself, has worked both in Sao Paulo and now in Doha. Very different strategies. Why don't you? What do you think, Grace?
Hi, everybody. So I'm a cardiac intensivist working here in Doha. And when Gil started with all of this idea of this webinar and then told us to answer these questions, it came to my mind to talk specifically about ECMO, because ECMO is something that has a big impact on this neurological development of these kids and all the complications that we know that they can have. And thinking about these 3 questions, specifically for the patients on ECMO, but we can use for the other patients as well. I think what we should continue, it's something that I think we do pretty much well, at least in my practice, is to get the family to be together. So we talk to them before starting ECMO, during all the ECMO run, and when you're about the cannulation, about the possibilities of the future, how this patient is will need to be followed up, and all the therapies that this patient probably is going to need, what the outcome could be, and how we can proactively help them through this journey, even when this is out of the intensive care. I sent a text message to a family today that they're very kind. This kid was on ECMO, VA ECMO for ECPR, 22 minutes of low flow, when she was 3 years old. Now she's 10. And the mom is very kind to me, always send me pictures of the kid, and she sent me the scores at the school, and she's doing very well. And then I just said, hey, amazing. And what specifically are we doing? So the mom started to describe the routine of physiotherapies, phono, and the mom herself, she was a psychologist. She studied neurodevelopment, and now she's doing a post-graduation on rehabilitation. So she's completely immersed in this universe. So to have this great outcome that kid had, for sure, we tried to provide a good ECMO for her, but the involvement of the family, understanding what could be done during the ICU admission and after that is very important. So I think we should continue to do that. What I would start to do, I think we start to, at least in my practice, I don't know how it is for the other colleagues, to think more about delirium and how we can prevent and how we can treat non-pharmacologically the delirium, something that unfortunately we forget about. We talk about sedation, we talk about withdrawal, but sometimes we don't understand what this patient is behaving that way. And when we diagnose it, sometimes we go straight to the pharmacological treatment of the delirium, and we know that is not the way to do. So something I would start to do more. And what I would stop, this is really on the clinical perspective, what I can do for my patients while they are in the ICU, while they are on ECMO. And first is I would stop to tolerate soft blood pressures. This is something, I don't know if we brought this from the OR, when the patients are for a few minutes or for a few hours, the maximum. And when they are on hypothermic, they accept soft blood pressures. And sometimes we transmit this to the ICU care while the patients are on ECMO, especially that soft blood pressures are okay. Soft blood pressures are not okay. We know by research that hypotension is very bad for the future development of the brain of this and the problems that this kid can have. And another thing that is easy for us to forget, so I would stop to do that as well, is to accept low CO2 and a high PaO2, especially when I start my ECMO run. This is very common and it's very easy to happen when you are starting ECMO, and we know that it's not good for the brain as well. So it's something I think we should pay more attention and stop doing to tolerate all of these things. I think that's pretty much it.
Yep. Grace, thanks. Amy Jo and I started working together a long time ago, and your career has just taken off. Amy was a bedside nurse when I was attending, and to see you be the expert in this field is just wonderful, well-deserving. And I'm sure you could have given the entire webinar. So I'm hoping that you can sort of cull down all of your work for a decade into a couple really important take-home messages for the crowd.
You are way too gracious, Gil. It is a privilege to be here with all of you. And for those of you who don't know, I'm an assistant professor at the University of Pennsylvania School of Nursing with a joint appointment in the Research Institute at CHOP. And as you've heard from Melissa, developmental care is, of course, an approach to care that is overarching and comprehensive, including all the things that Melissa mentioned. I would also add that it includes additional aspects to care that include cue-based feeding, the provision of human milk, and developmentally supportive feeding. I don't know that we've talked enough about feeding and nutrition here in this webinar, but not surprisingly, what I believe we need to do is to start funding comprehensive inpatient developmental care programs in our cardiac centers, much like what we've heard Melissa's amazing team at Children's National has described. And I absolutely applaud you, Melissa, for your work. Currently, we know that developmental care is not routinely budgeted for or integrated into most pediatric cardiac programs. Research is repeatedly demonstrating that resources allocated to developmental care and the infrastructure varies across programs, that practice implementation varies, and that documentation varies. There's often lack of education and time, dedicated staff and leadership, and other resources to ensure that each infant is universally receiving developmental care over their entire hospitalization. So that's what I believe we need to start doing. What I believe we need to keep doing is to continue our priority of providing family-centered care. I'm really excited to hear so much in this webinar about parents. And I'm sure that the vast majority of the children's hospitals and cardiac ICUs represented here on this panel, as well as many in this audience, that the hospitals and centers may tout family-centered care as a central approach to all aspects of patient care. I would argue, however, that I don't believe we've fully arrived, and that we need to continue to pursue family-centered care approaches, evaluating where we are lacking or maybe missing the mark in family-centered care, continuing to remove barriers for family-centered care across all disciplines and systems and across the lifespan of children. We know that social determinants of health can influence the overall well-being of children and their families, including neurodevelopmental outcomes. So we need to continue family-centered care, but push the envelope to tailor and develop family-centered care interventions to meet the individualized needs of families, no matter what their social needs or vulnerabilities are. So I think what we need to stop doing is echoing a little bit of what Melissa mentioned earlier about I believe we need to stop enhancing parental role alteration in the CICU. What I mean by that is we need to stop telling families that they cannot touch their baby. We need to stop telling families they need to leave the room for procedures or rounds. And I think we need to stop ignoring when we see parents sitting almost paralyzed at the bedside, afraid to touch or draw nearer to their baby. These moments are invitations for us to assess parents, their fears, their desires to connect with their child, and they're invitations for us to engage parents in communication so that together we can find ways to help them connect with their child. I think that while my research has repeatedly demonstrated that parental role alteration influences parent mental health symptoms, I think it also highlights what Melissa mentioned about that parent-infant separation and the toxic stress that babies experience when they're not connected to their caregivers. Thanks.
Thanks, Amy Jo.
We still haven't figured it out.
Working in the ICU is easier than Zoom. Jill is a member of the Marketing and Communications Committee for the World Congress, has been involved in PCICS and is a fantastic nurse clinician. And I'm really interested to hear your thoughts. You've been in 2 centers now in Texas. So tell me what you think with those experiences, Jill.
Yeah, thank you, Gil. Thank you for inviting me. The first thing that comes to mind initially, and it's something that's impacted me since I've been working in this. Justin and I worked together at Texas Children's, and we did developmental care rounds weekly on the parents. And one thing that, and I'm glad we talked about it so much today, is the maternal health, really the parental mental health impact, but specifically maternal health. Every time we would do developmental care rounds, we'd kind of end it with just talking to the parents and saying, how are you doing? What can we do for you? And it inevitably always ended in tears, but they needed it. And the first couple times we did it, it's a little bit uncomfortable for me, at least, because I'm like, oh my gosh, I don't know what to do. But then I think it's probably one of the very few times in their hospitalization that we focus on how are you doing? That kind of led us to work on how do we address the maternal mental health aspect. And I was a little bit discouraged to find how hard that is to do, especially at a place like Texas Children's that is attached to a women's pavilion. It was still hard to find a way to get these moms help. So I think one of the things that we need to start doing is we've identified that this is a problem. So how do we make it easier to get maternal mental health addressed and potentially treated? And I think that kind of goes to what Melissa was talking about, the messy middle of what happens in the ICU. But I think the messy middle is also what happens at home. We are really good about ICU interventions, and we're getting better at following up long-term outcomes, but we don't, at least in my experience, don't send these parents home fully prepared to continue to address their neurodevelopmental needs. So I think that addressing that aspect and what happens when they go home is something we should start doing. Something that we should keep doing, which I think that we do, but this is kind of an extension and we need to kind of take this a little further. We've talked a lot about modifiable income, modifiable interventions. But I think probably the most modifiable intervention that we can really work on is the care that's provided at the bedside, specifically by nursing. I think nurses, specifically ICU bedside nurses, I'm a little bit biased because I was one and I'm not anymore. I'm a nurse practitioner, but still have a role in that. I think that they're the MVPs of neurodevelopmental care. And while I think it's probably one of the most important things they can do at the bedside, we're just one group of people with a whole host of interventions that we want them to perform, while everybody else out there also wants the bedside nurses to perform different interventions. So they're kind of the catch-all of everything that each of our individual groups thinks is important. So I think we need to continue to place value on what the nurses can do at the bedside, but take that one step further. And this could be an entire task force, but how can they provide that care? We know that sticking a screen in front of a 6-month-old isn't the best way to calm them down. But when you're trying to keep your patient from self-extubating next door, sometimes frozen for the 700th time is just what that patient's going to get. So I think we can keep helping nurses provide developmentally appropriate care. And I think they're aware of what to do, but I think it's also our job as clinicians to also participate, but what are the alternatives? You know, what not to do, but how can we help you do what you should do? And then what we should stop doing is thinking of neurodevelopment and providing developmentally appropriate care as an option. I think obviously that doesn't really pertain to anyone on this webinar, especially this panel. I think we all find a lot of value in it, but I've been in a lot of conversations where there isn't a lot of value appreciated about these topics that I think some find as kind of fluffy, but that the literature very much supports that it's important to help them long-term as individuals. We've helped them survive. Now, I think we have more of a duty to help them thrive.
Jill, thanks so much. I appreciate people staying a few extra minutes. PP Rolleveld has joined us as well as a game time decision. PP's been involved in the ICU care, ECMO, just about everything, and is a great guitarist. Just in case you need to know.
Thank you, Gil.
What do you think, PP?
Please call me Peter. Gil. PP sounds a little bit in French is a bit, and English sounds a bit dodgy. But thanks for having me, and I'm really honored to be on this panel. I'm a pediatric cardiac intensivist from Leiden in the Netherlands, and I am not as deep into the research as most of the people on this panel are, and that's what I think that we should keep doing altogether, is keep building awareness, because like Jill said before me, I think there's still quite a few people out there in our community that don't realize well enough how important what we do for me in ICU and for others pre-ICU and in surgery all is for the late outcomes and quality of life of the patients. And that also, like the softer side of our care is really, really important. And we sometimes tend to think that that's not really important, but I think it really, really is, and that we should take that further. So what we should do more is more research into this, interventions like Eve already said, but what also frightened me a little bit is I noticed that there are more than 300, I think, assessment tools for neurodevelopment in children. And how are we going to compare all this? We should get together and decide on which tools we're going to use so that we can actually compare them and learn from. So that's what I think that we should be doing. And I really should be doing more parent empowerment. I think it's been mentioned many times before, but in general, PICU, it's been shown that if you start with empowerment in ICU, that really has a beneficial effect on the coping in the parents, less PTSD in the parents, but also on the psychosocial outcomes in the children. So really, really important. And for me, as a simple first thing that I can stop doing immediately in ICU with my next patient is telling parents that just giving sedatives for a procedure will make sure that the child won't remember, and it will all be fine in the future. It won't be fine. We know that children, even those who do not remember their time in ICU, might certainly have problems with their neurodevelopment and their psychosocial issues and PTSD in the future. So we should limit those procedures. We should take the parents and the child by the hand, explain it to them, and take them with us and do this journey with them together.
That's awesome. We save the best for last, because those of us who work in the ICU or in the operating room or anything along those lines, we can sort of read papers about what happens in the long run, but it's actually the people out there in the community who are finding these results. And Sarah's done a great job of feeding that stuff back to us who work in the critical care environment. So Sarah, again, Sarah Kelly is a psychologist at Children's Hospital in Colorado. She's an active member in CNOC, and you get to wrap this up. And just so people know, when you're done, I have one more question I'm going to ask on the word cloud on our AHA slides, and then Grace will sum it up. So Sarah, tell us how we're doing, what we need to change.
Great. Well, it's lucky for me to go last because I get a chance to oversimplify, to amplify many of the things that have been said already today by our wonderful panelists. So first, I think for stopping, like many of you said, we have to stop disempowering parents and caregivers at the bedside. We have to stop doing anything and everything that discourages them from touching, holding, or being present at the bedside. I also think anything that we can do to decrease their treatment burden, so stop adding to the treatment burden for these patients and families. I know this is especially hard here in Colorado. We do have a lot of families from a large geographic spread, so even just distance from the hospital is a challenge, but anything else that we can decrease. And then I think we have to stop accepting that babies and mothers are separated for long periods of time, or caregivers are not present at the bedside for hours, days, weeks. I understand more than many about the competing demands, but I think we need to stop accepting that there's not parental and caregiver presence, and that often that does fall to the MVPs, the nurses at the bedside, who have also a lot of competing demands. In terms of what I think we absolutely need to keep doing is multi-site, collaborative research, working together, multi-pronged interventions. We know that the risks are many, but we also know that small, teeny tiny interventions that you can do in the ICU can have huge impact. So even just a 1 degree change early on can have huge developmental trajectory impacts for that child as they grow older. And then I also think multidisciplinary. So certainly I think that this is not an individual sport. Neurodevelopmental care is a team sport. I absolutely love our team here. We do have somewhat of a luxury of having cardiac specific and dedicated psychology, neuropsychology, therapists, child life, social work, et cetera. And so I think moving forward as a field, we need to agree and advocate for what is a basic standard, neurodevelopmental and psychosocial standards of care that we demand, as well as then scaling up to really meet the needs. Not just checking off like, yes, we have this type of provider, yes, we have a neurodevelopmental follow-up program, but can we provide the right dosage at the right time? Similar to an antibiotic, you don't just give it once, you complete the series. I also think moving from this awareness to action is huge. In mental health and in neurodevelopment, we have interventions. We have effective and evidence-based interventions for mental health, for anxiety, depression, PTSD, for youth as well as for parents. In the ICU, there's many things we can modify to decrease the hostility of the ICU, but I also don't want the uterus to be a hostile environment. So what can we do between 20 weeks and 39 weeks to wrap around the support for the mother and the family to decrease the anxiety and that toxic stress that's impacting the already vulnerable fetus and brain. I think too, going way back to the early slides, is over time we've redefined which of these factors are unmodifiable versus modifiable. So I think we have to continue to rethink that. Often SES and social demographic, or even those plastics, those risk factors get lumped into the non-modifiable. I think we have to continue to think, how can we modify some of those factors? I'm not convinced that they're all non-modifiable. Automatizing and personalizing some of these neurodevelopmental care, the things that we know that work, making it easy and efficient that it happens in the ICU, and then personalizing it when we know that we can make it more specific to the family. And then of course, increasing the family and patient voice on these multidisciplinary teams, in the research, et cetera. So I think being able to make this, the ICU environment, as unnatural as it is, our team always refers to trying to make it as like home as possible. So that includes having the family bedside, increasing the environmental factors that make it a stressful and weird place to be, and then increasing the support for all involved.
Sarah, thanks for saying it. It's really interesting as you said that. I was thinking about as home as possible. As I think about the work we're doing with noise, much of the stuff that if my baby or my granddaughter was sleeping in the room, if somebody did outside that room where my granddaughter was sleeping at my house, I would throw them out of the house. And I think that we have to start to think about these microaggressions, because they all sort of add up to that. And I think what you had to say was terrific. So Grace, before you close us out, there's a couple of questions in the Q&A if some of the faculty would like to answer them. If you log back on to ahaslides.com/heart.brain, there should be the opportunity for us all to make a word cloud about what we all learned today. That should be on your screen right now. So if you can put that back on your computer or your phone or whatever. A lot of people are typing, which is great. It's great to watch this stuff come in. Hypoplastic. That might be my favorite one. There's 60 of us on here. The two biggest things we see so far are parents and mental health. And that's fantastic. You know, this was meant to be things we could do in the ICU. And we're settling out in the middle there with the most important thing we can't lose sight of.
Yeah.
Right? All right, I'm going to leave this up for just a second. More. I think I'm going to leave this up so it ends up on our YouTube slide, Grace. At the end, maybe we can use this as the, what do they call that? The image that you use that you post when the video goes up. Because 100 people have gotten together and clearly are seeing the major things are maternal health, mental health, parents. Those are sort of the big ones. Collaboration. And these are the things that certainly I had hoped we would get out of this webinar. I'm just going to quickly take moderator's privilege and do this. There's these word cloud programs online where you can just type in anything you want, and I put in all the words from my PowerPoint presentation, and this is what came out. You might want to try that sometime. You just copy the words and put them in, and you get to learn sort of, are you emphasizing the right thing? And I thought that certainly what I was wanted to talk about was what we do in the ICU sort of as I hate to divide it up, physicians and nurses, and therapists and whatnot, because we're all one team. My brain goes here, and my brain goes to be part of a team that does all the other stuff, which I think is particularly important. So I'm going to let Grace and Sasha close us out. I want to thank the panel, especially for, again, being so generous with your time and your expertise and all the research that you've done and all the care you've given all of our patients.
Thank you, Gil. And thank you all the panelists for being here. Thank you guys for watching us today. So this is really to give you just a flavor of what the World Congress is going to be. It's going to be an amazing, amazing conference. So please get prepared to join us in August and September in Washington, DC. Thanks for being with Congenital Heart Academy throughout all of these years. We have Dr. Anderson on next Thursday. Please join. And if you found this webinar interesting, please share the link of YouTube to your team and to your colleagues. Thank you very much, everybody.
Thank you. Bye. Thank you very much. Bye, Gil.
Thank you very much.
See you in DC.
One nation.
One station.
Station.
Bye-bye.